Good day. I'm Jan McDonald, and today I'm going to be discussing about cellulitis treatment in the community. So what exactly is cellulitis? It is the spreading of bacterial infection to the lower dermis and subcutaneous tissue here. And in the studies done in 2014 here in New Zealand, it was found that there was a 5% increase of skin and soft tissue infections. It was also discovered that Maori and Pacific people are at an increased risk to these kinds of infections. This slide here shows you the mind map that I have made for cellulitis. You can see here on the top, on the pink background, that's the concepts that I can find when I type cellulitis in SNOMED CT. So from what we can gather here, cellulitis is a skin disorder, it is an inflammatory disorder, and it is a disorder due to infection. It is a disease, and it's usually under the concept of clinical finding. The bottom part here is what I have made up from the different literatures that I have read. Let's start with the causative agent. So cellulitis is usually caused by Streptococcus, the Streptococci group. They compose 2/3 of most of the infections, or they cause 2/3 of the cases. Staphylococcus aureus and other causes. Other causes, for example, if a monkey bites you. So it is introducing a bacteria from its mouth into your skin, and that can give you cellulitis. And here, the finding site on the left, there's usual or common sites that you can find cellulitis, but it is not limited to this. Usually the limbs, periorbital site, perianal, abdominal wall, usually found in flaps or folds, surgical wounds. Of course, the skin has already been broken, so it's very, very prone to infection. And here in the middle part is the mild symptoms of cellulitis. We consider mild because it's usually localized and only in the area where it's affected. Fever, localized pain, swelling, erythema, heat, body malaise or feeling weak, and having an EWS of less than 8. For clinical people here, non-clinical people, EWS is an early warning score wherein we calculate the respiratory rate, heart rate, blood pressure, oxygen saturations, and the temperature. And if these mild symptoms are left untreated or they're not responding to the medications given, they develop to severe symptoms. And in this case, cellulitis, symptoms will usually be edema, swelling, blisters, ulcers, lymphangitis, and EWS of greater than or equal to 8. And that's when we usually call it a systemic involvement. So why DSS and cellulitis? For one, it's already been implemented and there's mild, moderate cases can be treated in the community. And there's existing paper-based pathways in New Zealand. And it also saves time for clinicians, and it makes treating cellulitis, having a pathway makes it more consistent in managing it. This is the domain model, or my DSS model for cellulitis. So here, cellulitis DSS. Let's start with the users. So who can access or who will be using these cellulitis DSS? So I was considering GP practices, A&Es, and hospitals. And which personnel can access this? In both these clinical settings, the GP and the CNS or the nurse practitioner can have access to these. because they're the ones who can diagnose and prescribe treatment for these patients with cellulitis. And in the hospital, you can also put in the ED doctors and the medical and surgical doctors. And on the bottom side here is who administers the medications medications to the patients. It's usually the CNS, nurse practitioner, hospital nurses, and these two here, district nurses and practice nurses, they play a big role when the patients are being treated in the community. And I'll talk more about it when I go over to this right side of the model. So on the right side here, I have data. What are we gonna input in this cellulitis DSS? So our input data would involve symptoms. Patients come in, we ask them why they're here. And for cellulitis, we would be categorizing the symptoms to mild, moderate, and for the severe ones, there would be what we consider red flags. And that would alert the clinician that there's a possibility of a systemic involvement going on. You also put in the finding site where the cellulitis is occurring, and medical history. If the patients, for example, have diabetes or chronic heart failure, then you would have to keep a closer eye on them because they've got slower healing. Social issues, you have to make sure that patients are well supported at home as well, and it's safe for them to be discharged because they would need all the support they get. And others, usually for mild cellulitis, you won't need any other blood test, you won't need any other test, but sometimes cellulitis can mask other diseases like necrotizing fasciitis or gout, and that's when these other tests come in, like the aspirate or the swabs when there's like an oozing pus coming out, and blood tests. They usually search for your white cell count or the inflammatory markers. And for the output data, we're looking at what would this DSS give to the clinicians. So for each symptoms, for example, the mild and moderate symptoms, it would give a suggestion to the clinicians of the possible medications or treatment that they can give to the patients. They can either choose oral antibiotics or give the first dose of IV antibiotics in the hospital or A&E or the practice, and then give the patient oral antibiotics to take home or a script. And if it's really quite a resistant or sort of a moderate side with cellulitis, and they would need IV antibiotics, so they can either go to a primary option for acute care, that's POAC, or if they don't have the means for that, then that's where the district nurses here comes in and goes to the patient's house to administer the drugs. And the limitation for this DSS is a severe kind of cellulitis, because when they've got the severe cellulitis, then the GP would be referring them to the hospital and they would require a hospital admission. And other outputs that that the DSS would be giving would be a follow-up, when to follow up the patient, alerts and notifications for the clinician, when to follow up, and alert or notification for the patient on when they're going to take the medication, and rest and elevate as well. So what drugs usually given to patients with cellulitis? Flucloxacillin, it's a narrow-spectrum antibiotic. If they're allergic to it, erythromycin. If they're allergic to both, cefalexin. And cefazolin for IV antibiotic in the community for POAC. And they usually give probenecid as well. It decreases the renal excretion of the antibiotic, but more studies are needed to support this. The limitations of the DSS would be basically hospital admissions or systemic involvement. And what will be the use of the DSS? For the main users, there will be a smoother flow and easier for them to diagnose and see if they would treat the patient in the community or in hospital. Saves time in a more consistent protocol and decreases unnecessary hospital stay. That's great, right? And for the patients, they would the alerts and notifications probably make them feel more supported and give them make them feel that there's a consistent management of their disease, and it lets them stay at home instead of being in the hospital. So that's it. Thank you for listening, and I hope you've learned something from this. Bye.